Thank you. Thank you, One Lambda Fisher Scientific, for inviting me, and thank you, ASHI, for giving me this opportunity to express my opinion. um, so let me. Oh, that's yours, right? That's not.
Yeah.
That's mine.
Yep, down.
Oh, okay. So that's my disclosure. It's my opinion, my lab's opinion, and nothing to do with One Lambda or One Fisher Scientific. So you've got two good, excellent lectures on how we be doing the virtual cross-match. First is about the allele specificity using the current technology of next generation sequencing to highlight. He highlighted the importance of allele specificity and how that can impact on virtual cross-match. And the second speaker actually showed how much we can clean up the existing class 1, class 2 antibody responses or antibody assignments which we get, which are non-specific, and how we can clean it up. So let me just give a tribute to the legendary Paul Terasaki, who started the serology, and we had serology for everything. Serology, for those who are old enough in this group will know that we have serology for typing, serology for antibody estimation, and then we had the cyclosporine, and that is what the transplantation was about. And then we went from there to current technological advancement, where we can now refine the antibody responses and make sound judgment to a certain extent in evaluating immunological risks associated with transplantation. And I really like to use that terminology because that's not just looking at virtual cross-match, but looking at the DSA or looking at the antibody titer or the MFI or even the physical cross-match. It is still, you have to use the human mind and the history of the alloimmune status of the patient in terms of, okay, how do you get one DR alone or one DQ alone or one A1 alone or one A2 alone? How do you get that kind of a response in a broad immunological response, which is normal in alloimmune response, because HLA antigens are so cross-reactive. So you should have some kind of a pattern, some kind of an immunological, logic in order to develop an immunological assessment. So it is important to have that kind of an insight to evaluate a virtual cross-match and a physical cross-match to guide the physicians or the surgeons towards it is okay to go for a transplant, or is it okay to, or how do you assess the immunological injuries post-transplant? Okay, so there are a lot of, I'm not going through these slides that, if you want, we can come back to that. Why do we use the One Lambda supplement? And in fact, if you see the slides, you'll see the supplement versus extended panel. So all our studies are the slides and the data which I'm showing in the beginning will be based on the supplemental panel. Now, those of you who are not familiar with it, we have the common, the regular single antigen bead1 and single antigen bead2 assays. And then they also have a supplemental panel for class 1 and class 2. You can do it supplementally in addition to the SAB1 and SAB2, class 1 and class 2. They also have come up with the XPlex panel, which is a combination of the original SAB1 and SAB2 along with the supplemental panels, okay, added to each group. So if I mention extended, it is the complete extended panel, which can include both XPlex and the supplemental. But the data which I'm going to show is always related to the regular SAB1 plus extend the supplemental panel. I hope that is clear. If you have questions, I will talk about that later. And then some of those things are missing there anyway. So overall, I just wanted to show the importance of HLA specificity in terms of virtual cross-matching and immunological risk assessment. I don't want to go through this because some of my slides are not showing up. Anyway, I can still talk about this. There are some, I don't know if you have, this has come in 2014, so many years ago, 8 years ago, by CDC guidelines for virtual cross-match for solid organ transplant and stem cell transplantation. There are, many of you probably already know about this. What are the criteria for having a very good virtual cross-matches? And some of them probably are debatable. Some of them are probably true. Some of them probably you should think about it before you make the decisions on virtual cross-match for both solid organ transplant and stem cell transplantation. At least we should know that we should have a nice, good, unambiguous typing of the HLA alleles in order to make a decent, reliable immunological risk assessment, whether it is virtual cross-match or interpreting a physical cross-match. The main important thing here is that indeterminate virtual cross-match. So what is indeterminate virtual cross-match, and what are the factors affecting those? So there are some of those things I have listed out there. You can, everybody knows that, okay, what is recent? What are the sensitizing events? What is the patient's history of allosensitization? Is it a male non-transplanted patient or a pregnant patient, multiparous woman, or a previous transplant? Do we know all those informations? Anyway, so the objectives are listed there. This is in terms of what we can do with the technology and the tools which are available from One Lambda, and see how we can utilize that in terms of a better informed virtual cross-match. So our lab, this is our rationale based on why we are doing the extended panel or the supplemental panel, and then thinking of implementing XPlux. So we do the NGS-based HLA typing for both solid organ and for bone marrow transplantation. It helps us to reduce the cost, and it is also important in, as I said, mentioned in that list, because it's important to do the virtual cross-match, immunological risk assessment again, interpret some of the physical cross-matches which are ambiguous. NMDP requirement currently tells us to do the initial patient evaluation so that they can avoid, just like we do UNOS and NKR, avoid the unacceptable antigens so that they can reduce narrow the search of unrelated donors. It will be more important for the haploidentical transplant and cord blood transplant as well. And then, of course, post-transplant DSA monitoring. It helps us to have better assessment of potential immunological injuries following transplantation. And this is one of the posters, actually. This is I can't remember the number, but P66 in the current, as today's, this ASHI meeting from, I think, UCS San Diego. I don't know where it is coming from, but it's in the immunology, it's in the ASHI meeting, this year meeting, actually. It's about the current assays or HLA antibodies may not completely exclude HLA donor-specific antibodies as the cause of HLA antibody-mediated rejection. So if you get a chance, I don't know how many of these type of articles are there in the current ASHI meeting, but it is one of the things which caught my eye. So, which means that we are currently inadequate in terms of calling an accurate, or at least as much as we can, what an accurate virtual cross-match is. Because we know, at least from our lab, we know that there are so many rare alleles, not so frequent alleles, and alleles which are not covered by the current panels by two major vendors. So we really do not know if there are HLA DSAs in all of the sera which we are testing. And all of the patients which we have, do we know that we are having a comprehensive HLA antibody profile, even after cleaning up everything, and even after having the, with our knowledge of HLA alleles of the donors and the recipients. So okay. So that's a list of the additional alleles which you can get from one lambda. That's for the class 2. So if you want to do this assay, you can either do a SAB 1 and 2 first, and then decide, depending on the donor and the recipient typing, and see which one you want to do, either only class 1 panel the supplemental or class 2 panel supplemental. Or you can have all these combined using their XPlex panel and then do it together. These are the two ways you can do it. So basically you will have a very comprehensive, as far as we know, as of now, a comprehensive HLA antibody profile. That doesn't mean that it is covering all the alleles. It is not. And once we know the frequency of the alleles in our population, as we see with NGS typing, we should be able to provide that information to these vendors and see how best they can incorporate those alleles into the panel. I think One Lambda has responded quite well with that so far, and they have got a good panel so far. That's so far, so we probably will need more. So potential for BMT and HSCT, that is the stem cell transplantation, it helps in haploidentical transplantation, matched unrelated donor selection where people are willing to do the transplant program. Again, it depends on the transplant programs. So some of the transplant programs are willing to go with some mismatches. Our transplant program does not. They go for 12 out of 12, mostly, except for DP. So the One Lambda has got some DP alleles, now new alleles, DP alpha and DP beta. And one of the centers, when I was talking to, they said that they had only one DP alpha antibody in the pre-transplant serum of a bone marrow transplant patient, and the engraftment did not work very well. So that's an important thing. So for bone marrow transplantation, where the program is going for mismatched transplant, cord blood transplant, and haploidentical, it will be ideal to do the initial extended antibody typing, because we see a lot of rare alleles and the not so frequent alleles in the bone marrow transplant recipients and the donors. So it is important for the bone marrow transplantation program, depending on the transplant program. So you can assess the supplemental or the XPlex panel in a very scientific way by looking at how frequently you were able to either include or exclude a donor, or how frequently you were able to find out a reason for immunological injury following transplantation. So these are very important thing in terms of the objectives and the ways to assess supplemental and XPlex panels in your workflow to support the transplant program in terms of immunological risk assessment. So this is one of the cases where we looked at the effect of extended antibody panel. Now, that is a misnomer, like it is used, it is not an Xplux panel which we used, it is the SAB 1 and 2 plus additional supplemental panel. So this was a case where we found the donor with a with a rare A allele, and then it was not necessary to do that because, and we did the typing, there was no antibody, so that donor was cleared. So that is a case where we could rule out. Now we don't have a case where we ruled in or then ruled out a donor. So this is a particular case where the donor had the specific allelic typing, but the recipient did not have the antibodies to those rare alleles. So this is a case where we could, say that, okay, this donor is all right to go with. But had that donor had that particular allele, then we should have gone for the extended panel. And if it didn't have it, probably the engraftment would have failed or at least got reduced. In our center for the bone marrow transplantation, like I said before, we do not really necessarily go for mismatch transplant, and we don't do that many haploidentical transplantations. So our testing is not that frequent, and we do that closer to the transplant, not initially. And now I'm going to get into some of the supplemental antibody profile of the recipients and the donor typing for the solid organ transplant at Rush University Medical Center. These are not protocol DSA assessment. These are for cause. So what they do normally in our center is that they depend too much on the allosure DNA, the circulating DNA in the serum, and then when they find something kind of spiking up, they send us for the DSAs to see if there is any immunological real reasons. So it's important for us to see if there are any HLA DSAs which we can detect. So this is one of the cases where we had a case, and then we did detect supplemental, extra antibodies. If you were to correlate with that, with the creatinine, yes, it did correlate. But I don't know the long-term follow-up of this patient because this is not that old. So in terms of the graft survival and issues from immunological injuries, I'm not sure about that, but at least we were able to detect some of these rare antibodies in that patient. This was another case where the supplementary SA1 was performed to test whether there was potential DSAs to 3906 or B5502, neither of which were there. That means that at least we ruled out those two DSAs pertaining to the donor. They must have had some other non-HLA or other cause of immunological injuries which not necessarily associated with HLA. This is a case where we did not have to do that because the alleles of the donor did not have anything to do with, we didn't have to do a supplemental antibody bead analysis for this. And some of these slides, now I'm going to show you 3 or 4 slides where you see the red ones. These are different patients, post-transplant monitoring. All those red ones are the donor-specific HLA antibodies, which are detected only by the the supplemental panel. Here again. So these are a few cases which I'm just showing. So we were able to detect in several patients post-transplant antibodies towards rare or the alleles which are seen only in the supplemental class 1 or class 2. So we did some validation to see if we can incorporate the XPlux panel, which is a combination of the regular class 1 and class 2 and the supplemental class 1 and class 2 into the workflow. So that's a validation to see if we can get the same kind of results. So we did limited ones, 30 class 1 and 30 class 2, and our results are, to my interpretation as to how we interpret in our lab, it is pretty good. Your results are kind of comparable in terms of whether you do it separately or you mix everything together and use XPlux panel. The ones which we miss either way will be the ones which are weak, which we classify as between 700 to 1,000 or 2,000 MFI. And again, I'm not a big fan of MFI because that does not really correlate with anything many times. It doesn't mean that if you have a low MFI, that may not have biological significance. It doesn't mean that if you have very high MFI, that's going to be biologically significant. This is kind of a relative level. Again, that is why I said that we have to incorporate our allied immune response, fundamental immunological information within our cells to see what it means. So the results, as I put it there, is 80%, 20%, doesn't mean that it's not completely correlating. It is correlating if you take the whole picture into account. So that 80%, 20% is only based on the MFIs. So if we kind of put those MFIs in perspective, probably they will have the same values. And I also want to make sure that anything which is more than 2,500 or 3,000 MFI or 5,000 MFI, you don't miss it. If you do it supplemental 1 and 2 separately or mix it together like using the XPlux. So basically the XPlux will do the same thing even if, like the way you were doing SAB1, SAB1, 2, and the supplemental panels. So the extended panel validation, which is XPlux, shows us that it is useful to do this, but all these were done in mostly very highly sensitized patients. Now, I would like to do that in lower sensitized, moderately sensitized patients, alloimmune sensitized, with not very high broad responses, and see how that works with this, and whether we are going to detect more specific, allele-specific antibodies in such patients. We haven't done that comparison with XPlux yet. We would like to do that because that will allow us to have a better idea in terms of our recommendation to the transplant team. So from the lab perspective, it is useful, and we need the typing of the donor and the recipient for the extended or the supplemental testing. And this will be extremely valuable for the heart-lung transplant people, because there are cases where the heart-lung transplant, they don't even have a prospective cross-match. Of course, it's not possible. And there are places where you can not even look at the autoantibodies because there are centers which I consult sometimes. They do not have the recipient typing. They only have the donor typing information. So it's very important to have heart-lung patient antibody responses extremely accurate. And then when you want to do it, how you want to do it, with XPlux or additional, I would, with my current experience, I would say that all the heart-lung patients should have extended, as much as possible, extended antibody testing prior to transplant to facilitate virtual cross-match, especially when it is done by the nurses. So the perspective from our lab, based on our current validation, is that to incorporate XPlux to our regular antibody testing for the bone marrow towards when they are ready to transplant, whether they, especially for the haploidentical in the cord blood, and then for the regular living donor program for the solid organ transplants, and for the deceased donors. Now, the limitations for the solid organ transplant will be for the deceased donors, the lack of adequate unambiguous typing, because the typing results from the real-time PCR, it's still not good enough, but at least we can utilize that information to see the potential alleles, and then utilize the post-transplant monitoring with extended panel, so that we will have some kind of better confidence, I would say, to evaluate the immunological injuries to the transplant, the allograft following transplantation. So overall, I would say that this is a nice tool which they have currently, worthwhile trying, and we certainly would, with a little more validation, we would try to implement the XPlux in our lab for the regular antibody monitoring. That's from our center experience, and I will stop at that, and thank you, and thank for my staff who have helped with me. Dr. Ina, she is currently our director in training. Michelle Prod, our lab supervisor. Maria Opperman, who does this antibody assays, and our pathology department for all the supports which they provide us. Thank you.